1. We are live now.
You can see my screen?
Yes, sir.
Yes, sir.
Which covers this terrible triad today. See, this is an elbow joint where lateral collateral ligament, medial collateral ligament, and these are the two bony radius and olecranon. Or now we talk about the coronoid process. These are the three things about it. Coronoid, radial head, LCL, MCL. Now, if the ligaments and muscles rupture, but the bones are intact, elbow is stable after reduction most often. If there is a posterior dislocation, ligaments are torn, but the bones are intact. What normally we do is we can reduce the elbow, immobilize it for a few days for the pain, and then we can start mobilizing. This is what is conventionally accepted. Today, I think some people have already put in that very small minority, only with the ligament injuries only, without any bony injuries, they can still remain unstable. So what is today's understanding is, after you reduce the elbow, before you mobilize, in about a week or 10 days time, reassess the stability. If it is dislocating again, then you have to be careful that you need probably a surgery or a reconstruction of any of those ligaments, mainly the LC. We are talking about mainly the LCL, which is the one which may need a removal. Now here, the normal isolated head of the radius and neck fractures. If it is only head of the radius and a neck fracture, but MCL is intact, LCL is intact. Now this one, if you excise the head of the radius, as we all know, we have done it for all throughout the life. Isolated head of the radius without MCL or LCL injury, then we can excise the head of the radius, and the elbow is still stable because MCL is still intact. Now this is what we have been doing it. Today, I think nowadays in a short time, it has now changed the situation that this is the one which is now we started replacing or repairing. So this is what is since MCL is intact, this is what is the one where you get isolated head of the radius. But before you think of excising, you will have to prove yourself that this is only an isolated and it is not disguised MCL cut. So when you see the patient, mainly it is if you get on the inner side, if you get ecchymosis, then you know that on this MCL ligament on the inner side is torn. And isolated head of the radius, the swelling in the elbow is not very much. But the elbow dislocation, which has automatically relocated with the head of the radius, which is fractured, generally the swelling is quite a lot, and the medial ecchymosis, which we will come in a short time, is there. So before you excise this head of the radius, you got to confirm that it is stable before you excise it. You also have to see after excising it that it is stable. Otherwise, so many times it happens that it is excised, and if it is unstable, you give a plaster and the elbow is completely unstable. This is what you have to confirm about. Now, radial head and neck fracture with the elbow dislocation. So here is the head of the radius fracture. Elbow is dislocated, so the MCL is torn. Such a fracture is unstable unless you either replace it or you repair it. Then you don't have to do anything to the MCL. Elbow joint is stable after fixing or replacing the head. Now here, radial head and coronoid fractures both are occurred with the elbow dislocation. So this is the head radius fracture and coronoid fracture. LCL is broken and MCL is also broken most of the time. So elbow joint is unstable unless both bony continuity is established with excellent length of the radius regained and Also the ligaments, if they are torn, you may have to repair it if the stability is not established after a bony reconstruction. Now, this is the ecchymosis I am talking about, the medial side. You can see this is the one which is very benign. It appears as if the elbow dislocated and it has reduced back. But you can see ecchymosis. This is a sign of a medial side that MCL ligament is torn. And this is the one, probably the LCL. This is coronoid is probably fractured. This is the one which is seen there. So now we all know with the terrible triad, if all bony structures regain their length, then only elbow becomes stable. Repair head of the radius, repair the coronoid, and most often elbow will stabilize. Repaired bones with original structures give the maximum stability. Head radius fracture can be repaired to normal shape when there is a split fracture of the head, which is repaired, or two part of the fracture, which can be repaired or anatomically repaired. Like you can repair this head of the radius with this plate, and you can get a normal length of the radius established. But the chances of everything established are highest into this sort of a split radius, which you are putting a few screws only, and you re-establish the head of the radius. But if you're putting the plate, and you can see there is a fracture here, now there is a possibility that this remains slightly oblong, or it remains slightly short. So you may not be able to 100% establish all the time. That's the reason you repair the head of the radius and again test for the stability of the elbow. Now see, this is a very complex problem. So if anybody has a problem in between, please stop me and ask me. Please do not hesitate. Now, open reduction and internal fixation of fracture of the head of the radius. Ring and Jupiter. 13 of the 14 patients with the meson type 3 comminuted fractures with more than 3 articular fragments had an unsatisfactory result. You can see you repair this with 3 or more fractures. This is a possibility of a non-union. Associated fracture dislocation of the elbow or a forearm may also compromise the long-term results of radial head repair, especially with regard to restoration of the forearm rotation. And their conclusion is our data suggests that open reduction and internal fixation is best reserved for minimally comminuted fractures with 3 or fewer articular fragments. So if the head of the radius is 2-part, you must repair. If it is 3-part, big 3-part, if you can repair, then it's fine. But if it is more than 3, then it is recommended that you do the replacement rather than the repair, because the results of the repair with more than 3 is not very good. Now here is the fracture. You can see this is the fracture dislocation. Here is the dislocation. This is the coronoid, and this fracture, the elbow joint is dislocated. These are the CT views, and you can see the CT here very well. Elbow is dislocated with the fracture there. Now here, since the elbow is dislocated, first we replace the head of the radius. And having replaced the head of the radius, we see for the stability. So here is the head of the radius, which was comminuted, which was not repairable, and so it had to be replaced. So once it is replaced, now see for the stability. After the replacing the head of the radius, till the elbow is not stable. That means we have to go further. So now, having done that, you repair the LCL ligament. So this is the LCL ligament we are trying to LCL stitch with the anchor. And here is the ankle, and we stitch the LCL. Till after stitching the LCL also, you are seeing it is not stable. So still it's not enough. So now we go there. This is LCL is stitched, and you can see this is dislocated. So you have to see the stability in almost short of full extension. And this is the typical way it is dislocating around. So head replaced, LCL is replaced till it is dislocated. So now you can see the MCL on the opposite side. This MCL is stitched. This MCL is stitched, and now you can see the elbow is fully stable. So the treatment of a cerebral triad is replace or repair the head of the radius and see for the stability. There is no stability. If the coronoid is fractured, repair the coronoid. If the coronoid is not fractured, repair the LCL ligament. If LCL ligament is sutured, most of the time it will be stable. If it's still not stable, suture the MCL ligament. And then the elbow will be stable. As you can see here, the suturing LCL, Now here is the patient. Here is the patient, 10-year-old child, called 5 days back. You can see, this is the time he came. He came with the elbow which is relocated. When presented with the complaints of pain, swelling right elbow, initial X-ray showed a posterior dislocation elbow with a radial head fracture. Elbow was initially reduced immobilization in AO slab. At this stage, he presented to me. Now, you can see this is the head of the radius, but you can see the CT scan. This is the head of the radius in AP view. It has gone on to the medial side. This place, it has gone on to the medial side. You can see this is dislocated. Head of the radius has gone on the medial side. It's a typical way. You can see the CT scan. This is the head of the radius. It has gone down. It has displayed. It has cut out from there, and it has gone on to the medial side. You can see how much it is fractured. But you can see it is one piece with this sort of a fracture there. So it went down, and you can see keep the fracture stable, but otherwise it is difficult. So we went down first on the medial side and removed the head of the radius. Now the head of the radius comes in the hand. Now you go on the radial head is approached through the anterior medial approach and retrieved in its entirety. Now the head of the radius is, because this is a 10-year-old, so we repaired it with this leg screw. So as you can see, as I told you, there was a piece of bone there. So from this, we put in the repair. So now it was repaired, and then the elbow was made stable. Now you can see here, even it is replaced, even it is repaired. Now we are seeing for the stability part of it. I opened the anterior medial because it was still unstable after even we did the head of the radius repair. It was unstable when I tested. Now, see, this is the one which is very beautiful. This video shows. I open up on the anterior medial incision, head extracted out, anterior capsule with anterior MCL is exposed. This is since after repairing the head, it was not still stable. So the same anterior incision, I exposed the MCL and the anterior capsule. Now you see the whole stability part which I am doing. I am putting the stitch. The stitch. It is not tight. You can see the elbow is dislocated. So it is dislocated. Now you can see. Tighten the stitch. I put it there. It is dislocating out because it is not crossed. Now I am crossing the stitch. Tightening it. Now I am seeing the stability. Now I stitch the the MCL ligament. It's problem. It became normal, so I stitched up the MCL ligament. This is the X-ray after 4 months. Elbow is very stable. The head of the radius is healing up. And you can see this is 3.5, 4 months X-ray. This is 6 months X-ray. This is a CT scan after 6 months. Elbow is stable and the person is moving the edge. Here is at 1 year, so much is the range of movement of the elbow. And I have told him at some stage, if you need to remove the head of the radius once he is adult, then we may have to exercise the head of the radius to give him still better range of movement. Last I discussed with him, he says he is almost normal except because he is from out of town. So he has got a small, short of a full extension is there. This is almost short of a full flexion. This is what it is. And you can see he has got a supination, and at that time the supination was restricted. But afterwards, unfortunately, he has not been able to send me the pictures. Now here is the other case. This is the patient I inherited, fracture olecranon on day 1 with the fracture head of the radius and the coronoid. You can see all these things. That surgeon had only fixed up the olecranon, thinking that he has solved the problem. But you can see here it is already dislocated out. This is already dislocated. You can see it very well when we did the CT scan. So now this is where it is. Now you can see this. This is the part which is going on the radius side. This is when I was talking about the olecranon wiring, I said you got to see that it doesn't go onto the radial side. This is the one it is going on the radial side. And when intraoperative, I'll show you, I've not been able that this was hitting onto the radius. That's the reason this olecranon, when you do the tension bend, it has to go anteriorly, but it has to also go onto the ulnar side and not on the radial side. Now here it is. You can see the head of the radius was tilted. When I opened up this head of the radius, I thought it is badly comminuted, but fortunately it wasn't comminuted. It was tilted and compressed here. So this is the one where you can see, this is how I made the thing. From here, I made it straight and then put in the wire that you can see here. So once it was done, it was corrected out. And then the way it was corrected out, and this is the wire which was hitting out, as I mentioned to you. So the head of the radius, after corrected out, I put in the plate. And I removed the wire. You can see here, this gap which was there, I put in the allograft. Because once the head is corrected, there was a gap which created here. So I put in the allograft there. I reconstructed the olecranon. And as I said, I go down into the triceps, and it is behind the triceps, reconstructed the olecranon. This is how it was. This is where it was hitting. And as you can see here, this is how it is hitting the wire. When I took it out, it was on the radial side. It has to be in the lateral side. It has to be onto the AP side. It shouldn't be hitting the radial side. So here it is, I changed it, did the plating, did the tension bend, and here is the range of movement. You can see I sutured the LCL also. I sutured the LCL. This is a good range of movement. This is the supination condition is restricted. But in due course of time, it came back everything. Now here it is a ring concept. If the head of the radius is fractured on this side, head of the radius fracture, this side, the opposite side, this is compression, opposite side will have to become higher. So here, on the medial side, if there is an injury, then the LCL will fracture. If the injury is there on the radial side, MCL will fracture. This is a typical ring concept. Medial collateral ligament, coronoid process, medial epicondyle. All these are the things, this is what is there. So if the head of the radius is fractured, it will go like this. So the MCL is going to be ruptured. The same thing when the coronoid is fractured, LCL is always ruptured. This is what is the ring concept. So this is how you have to expect the situations. Now, as you can see, this is the head of the radius is gone, so the coronoid, the MCL department, the ligament has to break down. So the MCL has to break down along with the head of the radius. This is the side slip injuries which we talk about.
Sir, video is not there, sir.
Yes, sir. We can't see. We can't see anything, sir.
From beginning or only now?
Just now, sir. Just now, 1 minute, 50 seconds.
Oh, I see.
After the ring concept was seen.
Oh, I see. I'll leave top share and I'll go back.
Yes.
I'll go out and come.
Yes, sir. By that time, Dr. Tanna sir joins. How difficult it is to operate terrible triad?
It is difficult indeed.
And what is the most difficult step you find?
When we repair this coronoid soft tissue.
Coronoid back into position.
Yeah.
Yeah.
Very small.
So the difficulty is getting the catch or delivering it out or tying it. What is the difficulty?
I found difficulty in tying. Once I tied ulnar nerve over my suture.
Okay. So the difficulty is in precisely picking up the coronoid with the anterior capsule.
Yeah, but sir, when this everything is dislocated and head radius is in our hand, we can suture. Suturing is not difficult. Taking a bite is not difficult.
So taking the bite is not difficult, but catching it and getting it delivered into the ulna and then tying. So the whole process.
That process is because once I got this ulnar nerve palsy, then I started seeing something opening and then tying it, because once you bend your tongue, it becomes difficult sometimes.
Okay. Sir, we were just discussing what is the most difficult part of the terrible triad. So he was suggesting that getting, you are muted, sir.
Tandal sir.
Yes, please go ahead, Rajendra.
Yeah.
Good evening. Good evening, Bolo.
It's a really difficult task to find out the soft tissue reconstruction. The whole thing is tumbled over there, and you cannot find the sometimes the lateral, collateral, even the coronoid part is really a difficult part of it.
So you suggest you have difficulty in identifying lateral ulnar collateral ligament, one.
Yes.
And taking the coronoid with the anterior capsule.
Yes.
Okay. Sir. Okay. Fine. Got the point. So that we'll stress on those points. Yeah. I think sir is ready with sir's presentation. Now it is very clear, sir.
Sir, you are muted, sir. Tanna sir, you are muted.
You are muted.
Yes, now it is very clear, sir.
Now, if after fixing the head and the coronoid and suturing the LCL and MCL, still the elbow is unstable, this is because probably the head of the radius, you have not been able to suture to the extent which you want to have the reconstruction of the length. And if any of the four structures are not perfectly reduced, then the only solution is hinged external fixation if the elbow is still not stable after everything. Now, our scenario, lack of expertise for the head reconstruction and also the expensive implant, difficult availability of good radial head replacement prosthesis all the time, everywhere, and a cost constraint. Now, this is what I had reported in 2013. Elbow dislocation with fractured head radius, Indian Journal of Orthopaedics. Excision of the head radius, now joint is very unstable. Re-establish the secondary stabilizers by suturing the medial collateral ligament complex with the detached muscles. Then the joint becomes stable now. This mimics the isolated head radius fracture without dislocation, where the excision is not a big problem. Now, are you clear about what I am talking about?
No video.
Sir, your screen is on again gone.
No video, sir.
Screen is black, sir.
There is no video.
Oh. Chandok, can you take over?
Yes, sir. Yes. So we are actually seeing your screen. Only thing is there is nothing seen on the screen, but we are viewing your screen.
Yes.
So the message we are getting is you are viewing Dr. Tanna's screen, but actually there is no video. So if I think
your arrow is seen, sir.
Cursor is seen.
Are you seeing my PowerPoint presentation here?
No, but screen we are seeing. The PowerPoint is not seen. So I think again you will have to just close your presentation and then restart. I think it would come. And if you optimize the video before joining, that also would be better.
Till the meantime, you carry on.
Yes. So Rajendra, continuing with our discussion.
Sir. Yes, sir.
Good evening, Negi, sir.
Dr. Negi is also here. Yeah, Negi,
yeah. So we were discussing terrible triad. Sir presented terrible triad presentation, and he presented very nicely the radial head, the reconstruction, plating, reconstruction of lateral collateral ligament. Good evening, Adegone, sir.
Namaskar.
Good evening, sir. Namaskar.
Good evening, sir.
Yeah. Tanna sir is again reconnecting. He started presenting.
Sir,
yeah.
I just want to know if the radial head, as sir said, if it is accumulated more than 3 pieces.
Mm-hmm.
So one should replace it with the replacement, I mean.
Right.
So is there any age limitation or criteria not to replace the head or something like that?
Nothing like that. The stability is the most important concern, whatever age it is. So okay. obviously you are not going to replace in a pediatric age group. That is That is for sure.
Yeah.
Because pediatric size radial head prosthesis is also not available, and also pediatric heads are never chura. They are not multiple pieces.
Correct.
Usually it is one single piece of neck fracture which is displaced 90 or topsy-turvy. So
Yes.
which is very easily reconstructed. So in
Correct.
the pediatric age group, it's not required. And in adult beyond 18 years, up to any age, you can replace the radial head.
Okay.
And radial head replacement is not a big task. You just have to understand the fundamentals.
Correct.
And the fundamentals are very clear.
Mm-hmm.
Right? So don't resist replacing.
Okay.
It's not at all difficult surgery. At the most, yeah. Yeah,
There are more than 3 pieces in an adult.
Mm-hmm.
Or maybe the age. There is no choice. More than 3 pieces are simply irreconstructible for the experts also.
Yes.
Yeah. So if there are more than 3 pieces, but all 3 pieces are large or 4 pieces are large, then it can be reconstructed. But when very small articular fragments are there which have no sense in reconstructing, I think then again it is better to go ahead with a metal head replacement.
Previously, we used to get only one size of the radial head. So whenever I'm replacing, I ask 3 companies wala to give their product of radial head replacement. And all 3 companies, they make different. And nowadays, Matrix offers you head radius with different neck lengths. So at least there are 8 into 3, 24 options available on the table.
Yes.
Yeah. And it's not very, very expensive, affordable.
Excuse me, sir. So I had tried Matrix radial head once. I have only tried it once only, but it was too stuffy. Even the smallest size was too stuffy.
No, that's not our experience. I have used it in a gynecologist, female patient, and that's not our experience. You go for a slightly smaller. If you are in between sizes, you go for a smaller size.
Sir, can I ask one thing?
Yes, please go ahead, sir.
And I get it from 2 other companies also. So if I can't use that, I switch over to second company or a third company. So anybody who keeps head radius in Indore, all of them are asked, please keep it. Whatever fits best will use.
Sir, in case of a radial head fracture, if it is, suppose it is 3 part, 2 big chunks are there and 1 small articular, suppose 10 to 15% of the radial head surface is there. So we should reconstruct it and remove that small part if it is not fitting properly, or should we go for replacement?
So I think if your articular cartilage is well maintained and the side of the neck is missing, I think just stuff a very small part of cancellous bone into that void, and the soft tissue usually retain it very well. You don't need a very, very rigid reconstruction there. And a plate just to buttress it.
Okay. And suppose if 10 to 15% of the articular surface is missing.
Even 3/4 sector is reserved. That is good enough for radial head to give function.
Okay.
So, but it has to be 3/4 circle.
If the part articulating with the sigmoid notch is good, then probably you are through. At the end of the day, it's only a spacer. Once everything heals, soft tissue heals, even if it's excised, it won't make any difference. It's only for first 3-4 months that you need it.
And so many times, when we repair the head of the radius, all what we try to do is to get the length of the radius corrected. And so many times the supination pronation is compromised. But the elbow is stable. In that situation, you may need a secondary excision of the head of the radius.
Yes.
It happens with the replacement of the head of the radius. Most of the time, you get a decent range of movement after the head is replaced. But it is not a short surgery. So often you replace the head of the radius, the elbow has become stable, and then supination pronation is compromised. The results are saying that about 40 to 50% head of the radius need to be removed later on in order to give you a better range of supination pronation. And that's the reason the head of the radius, which is being done today, is never a cemented head of the radius, or it is never a bone ingrowth. It is a smooth surface head of the radius which has been pushed in, and it has been snugly fitting, so that wherever you have to remove, you will be able to remove it without any major problem.
Sir, may I?
Yes, bolo gaadi bole.
There is no statistical evidence that the radial head replacement without cementing, that it works always, because loosening, migration, and painful movements are described in literature. And therefore, if it is to be done, it is to be done very perfectly, in that the radial head should move in the sigmoid knots, not in the trochlea. Is not a very difficult job, but in sigmoid, then it works. Otherwise, there is a problem. So it is a new thing and it can be done, but it should be done with a caution.
So that's the reason there has to be a very tight fit. So as Dr. Asim mentioned, if you have all sizes of the head of the radius with the stem which is different, then you will get a good fit, which is going to give you a good stability and the supination pronation. But the via media of cementing, if ever you have to remove that head which is cemented, is going to be damn difficult to really do the cemented head removal. Then you will have to just completely forget about supination pronation and accept the elbow, whatever it is.
Yes.
Gadigode, have you ever tried to remove a cemented head?
I have not done it and I have not removed it.
Please, sir, whenever I replace and reconstruct other things, I am really aggressive in mobilizing them in first knee with an elbow hinged brace. You have got enough stability there to start guarded mobilization.
And if the stability is not there, then the surgery is useless.
Yeah.
So the whole surgery is to give you the elbow stable. Now I proceed a little further.
Yes, sir.
Our tenor of the lack of expertise for the head reconstruction and also the expensive implant, difficult availability of good radial head replacement prosthesis, and cost constraint. Only in the metros now a good amount of head of the radius variation is available. But I remember 2 years back when we were doing, there were only 3 head of the radius which were there, 3 to 4. So now here, this is the one which I had suggested at that time. Extrusion head of the radius, and now the joint is not stable. To re-establish the secondary stabilizers by suturing the medial collateral ligament complex with detached muscles. This mimics the isolated head of the radius, which I spoke to you. That when you talk about the isolated head of the radius, which before the repair and replacement came, all of us have excised this head of the radius, which was not repairable. And then it didn't give us any problem. But the prerequisite was it was without dislocation and without the injury to MCL. The MCL was intact. MCL repair in elbow dislocation is not needed if the radial head is reconstructed. If radial head cannot be reconstructed, then it should be replaced. This is what all the literature talks about. Now we are converting dislocation without body injury as a reconstructed or a replaced head gives a primary stability. This is when we replace or repair. Now here you can see this is the patient where it was not repairable. It had to be replaced. But somehow or the other, I had a feeling that the head of the replace, that time when I was doing this replacement, very few replaced heads were available of a good size. So here, this was a doctor. So I went ahead. This is MCL, anterior fibers of the MCL. So I went in and I sutured these MCL fibers of the MCL. I excised head of the radius, went to the medial side and sutured these MCL along with the medial complex. Now this is the same patient, medial injury. All the common flexors on the medial side were ruptured, and this is the typical MCL anterior ligament which is there. This is the ligament which was fractured. So I went down. I readjusted the common fracture attachment, sutured the anterior column of the medial colletal ligament. You can see here, this is the typical ecchymosis which was there. This is the head of the radius, and you can see the stability. So suturing the MCL, I got this stability. So I did nothing. This is the patient. This is the post-op X-ray, and here is the range of movement, full supination, full pronation, and an excellent flexion. So nowadays he is still in contact with me. This is sometime way in 2013. So this is already 9 years. He has a full range of movement and movement which is there. You can see it very well. 31-year normal movements. This is another case. The head of the radius was displaced. Somebody excised it, and he came along with this elbow dislocation. So this you never excise unless you are 100% sure that elbow is not, the MCL is not ruptured. Primary stabilized head radius, which was keeping elbow stable, the secondary stabilized MCL is already torn, so the elbow is unstable. As you can see, when the head is not excised, it was stable. Once you excise the head, whole thing became unstable. Because this part of even head which was slightly angulated, but still the head which was there, it was giving the stability. So now this was the small piece of radius with crushing, which needs fixation. I couldn't fix it at that time adequately, and hence excise. And then see the valgus stress, you can see the MCL is completely torn. So I again went down, anterior fibers of MCL, this is the anterior fibers of MCL. This is the anterior fibers of MCL. So I stitched it back, and this is the one which you can see. This is the medial for the MCL construction. And this is the excellent good range of movement which is there. This is the incision for the head excision. This is the incision for MCL repair. It is not only integrity of the bone, but the exact length of the radius is important for a bony stability. As you can see here, you have replaced. But since the exact length has not been replaced completely, elbow becomes unstable. And you can see here, when you put in a stem like this, it can get fractured. Or here, it became, the patient became quite painful. And this is the one ultimately I had to remove it. Now there is about the coronoid. This is the repair of the grade 1 is not significant. This is how the coronoid fracture. Grade 1, grade 2, and grade 3. Grade 1 is not significant. Second and 2 and 3 are major reasons for instability. Repair of this anterior capsule which is here. This is the anterior capsule which is here. Is important in grade 2 and grade 3 along with fixation if possible. So many times the pieces are so comminuted that you may not be able to fix up the coronoid, but this anterior capsule with the pull-through switches through here is the one which is important. This is the way in which this allochronon is fixed up. As you can see here, with the ACL jig, you can really find out where you want to go. So put in a stitch, come out over here, and you will be able to get there. Now here was the patient, again a doctor from outside. He came with this elbow dislocation and the big coronoid piece. This was the one which was there, the coronoid piece which was there. He came late to me. So after some time I had to go down. So I did the medial epicondylar osteotomy. I went down and fixed up the coronoid. I put the screw from here to there. The coronoid was stabilized, and then ultimately the elbow is very stable. You can see this is the X-ray he sent me afterwards. That how much is the range of movement. So he sent me this X-ray. This is the flexion. This is the extension, and he was perfectly honest. His initial problem was this screw which is jutting out a little. It was hurting him for a while. After a few years, I went to this place, Amravati. I went to Amravati, and at that time he came to see me. And he said, sir, this is the one which is hurting, otherwise the elbow is normal. I said, the only way I can probably treat it is with the metal cutting bar, I can bar it out. Then he said, okay, sir, I'll decide and come. But he didn't come. The second time after 2 years, I went to Amravati. He said, now I'm not paining, probably a small bursa has formed, and it became perfectly all right. So approximately 40 to 50% of radial head replacement needs removal for stiffness. So never cemented or a bone ingrowth stem, always a smooth, well-fitting replacement stem is the one which is needed. This is the one which I had done it. Initially, I couldn't do the head. It was stiff, so I removed the head, they stick the head of the removed, and arthrolysis. Arthrolysis was done 1 year after the first operation. And ultimately the elbow is stable and the head is excised. Because this was removed, it gave us stiffness, so I had to do arthrolysis. Here was the case where somebody had excised. I tried to repair everything, LCL, MCL, everything. Now external fixation I didn't have. So I put in this ball K wire. And you can see at the end of the surgery, this is the range of movement she got after in the forearm. So the radial fractures. This is the terrible triad. You can see Dr. Mukhi's case. This is how it was. So he went down, he reconstructed the head of the radius outside, and the complete same size of the replacement was done, which is, you can see it here. Excision is disaster. All these pieces you have to replace. So he replaced it. He sutured the LCL, which you can see it over here. And then after 2 months, is the excellent range of movement and everything. So this is the one which works very well. After 1 year, this is the range of movement. LCL, supinatal pronation is there. After 6 years also, this was a good range of movement. And as you can see, this is a tight fitting head, but it's not cemented or is not a bone ingrowth. This is the range of movement. 3 months old dislocated. Asim, can
Excuse me, sir.
Asim, can you take over this, your case?
Excuse me, sir.
Yes, please.
So what is the point where we have to resect radial head? Only where the fracture is at the same point, or we have to sometimes resect it more or adjust
No. Do not excise anything more. Keep the edges which are rough, you keep them rough. You do not try to make it smooth.
Okay, sir. So MCL is only to be repaired if there is instability. If we have replaced radial head and after MCL there is stability, then MCL is not to be touched.
Majority times you will have to repair MCL. So first head of the radius either replaced or repaired, coronoid repaired, LCL repaired, and then see the stability. If it is not stable still, then go and repair also the MCL.
So coronoid pull-through suture has to be taken through the radial window only, or through separate incision, or through midline posterior approach?
Very good question. You can take up through the radial incision. If you need a replacement of the head, then you have excised the head already. Now you have enough space to treat the coronoid there. So before putting the head replacement, you repair the coronoid, you have ample space there. And also I have seen again, initially what we used to do is, if the head is to be repaired, then we used to go on the medial side in order to fix up the coronoid. But if you really are well versed and we have done enough experience, then even with the head which is intact there, or with the repaired head, still you can go slightly more anteriorly and you will be able to see the coronoid and you will be able to fix the coronoid. I think it is demanding, but for people who are doing infrequent surgery, you should go onto the medial side if the head of the radius is intact. Or it is repaired.
Midline posterior approach is not recommended. Using 2 approaches is recommended.
Yeah.
So, and in medial also there are 2 to 3 approaches. One is Hotchkiss approach, one is over the coronoid approach. Which approach to use for coronoid approaching, and do you fix coronoid with mini plate also or only with pull out suture?
Coronoid, if it is a small piece, it will have to be only a pull out. If it is a big piece, then you can put in a screw fixation.
And sir, which approach medially? There is one Hotchkiss approach. There are 2 to 3 approaches for medial side.
See the approach. So you go medially anterior to the MCL. Anterior to the MCL, so you do not damage the MCL if it is intact. But if it is already damaged, then I think it is much more easier. Wherever you go, you will be able to find it. Yeah.
Harjot, if I can answer that.
Yes, sir.
Yeah. So there are 2 approaches, Harjot, medially. So the basic approach is you explore medially by a medial incision. You identify the ulnar node. That is the first prerequisite. And explore it till the first branch to the flexor carpi ulnaris. Then you have now 2 approaches to go. One is reflecting the flexor origin or then over the top. If you are having an over the top approach, what you do is you erase the pronator teres origin, go to the medial facet of the coronoid, and then just have an incision in the flexor muscle, and then you are bang there for a screw fixation. So these are the only 2 things. That's all.
So do you sometime approach midline for both radial head and ulna or coronoid, or always to approach?
Always to approach. Midline approach is a very windowish approach. There you in the tunnel you see something. Here the lateral approach is very comfortable and you can see the whole thing very nicely.
So enough cases when then whatever approach you can take, it is all right. But initially I would strongly say you take up the approach which you are most comfortable with and which is the standard approach.
Yeah. So can I present something about radial head approach also?
Yes.
Yeah.
Asim, you are there?
Asim sir is also there. He is muted. Asim, you are muted. Asim, you are muted. Asim, you are muted.
Asim?
You are muted.
Can you carry on, Chandak?
Yes, sir. I'll just go.
But this is his case, so I thought if he presents, it will be better.
No, let Dr. finish and then by that time I will load it. Yeah.
Asim, you know this case, it is your case.
Which one? Let Dr. Chandak finish. By that time, I will get it on the screen.
Okay.
5 minutes, yeah. So let him finish.
Chandak, you please carry on.
Yeah.
Yes, sir.
Dr. Sanjay Desai, have you joined?
Sir, able to see my screen?
Sorry, yeah, we can see your screen.
Yeah. So, radial head, leave it, fix it or replace it, and the approach and minor details about the approach. So, it's a very small presentation. The terrible triad was basically very terribly called because persistent subluxation or dislocation, chronic instability, and that were the main reason. So, this dry bone model would give you certain minor details how to execute the coronoid fixation. So the main difficulty is this space. So you are looking from this window from the lateral side. The incision is somewhere here. So this much area is open. And here is all palpatory initially. Then you put a small spike in front of the trochlea. And this spike is not continuously elevated 90 degrees. It is just 30 to 40 degrees is what you can get. And you have a beam of light focused here. You palpate this fossa of fracture. So coronoid is a small piece, But if you put your index finger, you are able to palpate this fossa. So now get a K-wire drilled from this window. A small incision, 1 centimeter is good enough. As you can see, I have drilled a K-wire. So the elbow is at 90 degree. So you just have a 1 centimeter incision here. Drill a K-wire.
The patient is prone.
The patient is supine. For all radial head work, patient is supine. So this is supine. So imagine this to be the patient on a sideboard. Patient is supine. To have a K-wire drill, your index finger is palpating the fossa of the coronoid. So as soon as you get a K-wire rotating there, you feel some hotness. Withdraw that. Enlarge this with a 2.5 mm K-wire. Just adjacent to it, enough to tie 2 wires. Just adjacent to it, have another K-wire drill. So now imagine this is the first K-wire. Another you can get on one side, or here. So get 2 K-wire drill. Once that is done, now your next task is, this is a very small piece of coronoid. To get a bite inside the bone is quite difficult. So you get the capsule onto it. So the first bite goes inside up. The second bite is upside down. So you get 2 loops. And then I take from this hollow, this hole, drilled hole, a small wire loop, 24 gauge, which is passed inside. It comes out here, and this wire is withdrawn, as you can see in the subsequent slides. So this is the needle. If you can get the needle in, you need a very small needle. What I would recommend is fiber wire 2O. The trade name is Clini Fiber. So that is a very small needle because the space there is less. Ethibond is a large needle, you can't drive it out. So this I find very convenient. Then you take it out, and this is how the wire piece comes in. The piece may not sit exactly into its position. If you want to make the piece sit exactly into position, and if it is large piece, what you need is over the top Hotchkiss approach, and then you put a screw. The experience with that approach is also not very good unless you put a mini plate. So this technique is best. The lasso technique is the best. You get 2 loops, or you can tie it on a button, and this solves the problem of coronoid fracture. Coming to radial head difficulty fractures. So all of us know all these 4 types. The difficulty arises when the fracture is like this, or if 2 pieces are there, then it is very easily fixable. So undisplaced, no doubt about this, you can treat conservatively, or you can put a screw. What I would recommend is, if there is one sector fracture and it is displaced, always try repairing this radial head absolutely accurately. What you need to do is to accurately position your screw so that you get more confidence into radial head fixation. The approach I'll just describe in detail. How do we get confidence and we don't worry about the pin? That is the posterior interosseous nerve. So this diagram I have taken from Dr. Andy Bindra's dissections. So this is how he describes it very efficiently, that this is radial head and this is point 1, point 2, point 3. The hand is in pronation. When it is in pronation, the posterior interosseous nerve is, this is the large distance away. So this area is totally free where we can dissect. So the approach is, you take an incision, then you enlarge. There are 2 layers of muscle which you have to incise, which I'm coming in a moment. Just see this diagram perfectly. So what he has recommended for radial head, no excision nowadays, replace if impaction, poor bone or very large articular comminution, otherwise fix it. So this is what he would go for fixation. And any fracture which causes the head of the radius to be deformed or smooth contour of the inner half its circumference is lost, will produce pain in limitation of movement. That you can replace, rest all can be reconstructed. So even after reconstruction, this patient had a lot of problems. Even after the excision, this patient had a lot of problems. So excision also may not be very easy and wise also. It may lead to instability, and it had led to problems in this patient. So we'll go ahead with fixation. So typically this is the patient. So there is a terrible triad injury, radial head is displaced, and this window of opportunity is there for us to work. So work is always from outside in, and then fixation is always from inside out. So this sentence is very important. Why? Because it gives you room for managing those fractures. So going to the first very simple fracture, sector fracture of the radial head. Now for everyone this would be very simple, but what you need is a very specific set of instruments, and you need 2.2 mm screws. As you can see here, this is a 2 mm screw, and which gives you effective compression and mobilization. I'll be also speaking about the instrument set you need and which is available for fixing these fractures. And then that was the patient who had an excellent result. Some displaced angulated fractures are showed very beautifully that you can unlock it into position. So this, you can go into this zone of fracture, what is known as 3 K-wire method. So first K-wire goes into this plane, you elevate the radial head, second K-wire goes into the second plane and then elevates further. And then once that comes into position, this is how it is done. So this is elevated, brought back into position. More commonly, this is employed for the pediatric injuries, but occasionally in adult, you can at least reposition it and then you can fix it with the metashoe technique as was done in this case. So metashoe is only possible for radial neck fractures, not for the radial head fractures, not for the split head fractures, and that was managed. So metashoe, what you need is very thin slender nail, only 2 mm, very exact length, and then that sector nicely positions it into a position of comfort. But when it is displaced, then the fixation is quite easy with the plate. This was again metashoe technique. When it is along with olecranon, in this patient also, since there was a lot of amount of comminution, etc., we had gone ahead with internal ballooning of both olecranon as well as the radial head, and that patient had excellent result. Coming to this patient, when that is radial head is totally displaced, it is gone like this, then you have to get it back into position, and this was a pediatric patient. So as you can see, usually in a pediatric age group, it jumps and comes almost 90 degrees. So again, you will have to go into epiphysis, get into that plane and get it back, flip it back into position. You may have to distract the joint to get the position into joint, and then it was fine. These were all simple cases. Now, what to do if the cases are complex and multifragmentary? Step number 1, 3 important things. Get 3 bold decisions. First bold decision is have a wide flap raised. So this is step number 1 for repairing your radial heads nicely. So raise large flaps. Once you raise large flaps, then you see the whole extensor mass. Once you are able to see the whole extensor mass, then your dilemmas and difficulties go away. So we remember this diagram. So you go along the diagram. We on the C-arm, we take a shoot, and we are usually on the equator of radial head. So if you are on the equator, you are not posterior, you are not much anterior. So the radial posterior interosseous nerve is way away, and you are keeping the forearm into pronation so that the nerve is moved away. So you are incising small, gently. So you identify the extensors. And second important decision and bold decision is to cut the extensors, which is what we would always worry that nerve is there. Remember, the nerve is way anterior. This is right elbow. We are looking from the side. Patient is supine. So this is proximal. This is distal. This is how you see from the external epicondyle the whole extensor mass. The second important decision is to incise the extensor muscle. So this is what is the second bold decision, because initially when we have not incised this anytime, it requires some amount of courage to incise the muscle. So you incise muscle, you give an incision in the muscle, raise this flap. Once that is done, you come to the capsule. So erase the capsule anteriorly, and then you see the radial head, and then you enlarge. The third bold decision is you get in the bed the supinator muscle. And the supinator muscle is at right angle to this extensor muscle. I am describing this in detail for those who might be attempting radial head fixations initially, and they should not develop the fear of posterior interosseous nerve. So the supinator muscle is now across. The upper layer of muscle is longitudinal, and this muscle you will find the supinator across. So this you can erase for almost 2 centimeters. Now you can see this is the muscle superficial, and this is the supinator muscle, which also you can exercise, and you can incise the annular ligament as well. So pronate the forearm and then take these 2 decisions. Now you visualize the radial head. As you can see here, visualization of the radial head is there. A small Gelpi retractor, a thin blade right angle retractor also is very useful. So also small spikes. As you can see here, a very thin blade right angle. And this gives you enough room to manage that radial head. Now you can see multiple comminuted fragments. And this is the set I was talking about. You need a very specific set of radial head fixation. So this has very small tongs, small holders for the radial neck. So what it does is, if there are 2 fragments, it nicely holds. It's something like a small Ellis forceps. This is particular mini fragment set. And you have all these small sleeves. These sleeves are very important, very, very important for radial head fracture, because you will be managing this small fragment fixation with 0.6 K wire, 0.6 mm K wire, 0.8 mm K wire, so that you can fix multiple fragments, even up to 4 fragments also you can fix. And this is the set. So this is 1.5 mm, 1 mm screw, 1.5 mm screw, and 2 mm screw. So even 1 mm screw is also there, which is very efficient to purchase small fragments. And this is the specific drill bit set completely available. And then it becomes a very, very useful thing. So remember, a very good instrument cell helps you and bails you out for a good fixation. So coming to this fragment, this was 4-part fracture. Now, how do we fix it? So you have a small K-wire joystick, bring it back into position. This is another construct. If 2 main fragments are there, this is also recommended. Occasionally that can be done. So this is, you take a K-wire. If you want to use 1 mm screw, drill with 8 mm K-wire. If you want to use 1.5 mm screw, drill with 1.2 mm K-wire. So you drill the whole thing, you know the length, then you place that screw across. And that is a very small fundamental trick that you fix with interfragmentary screw, and then you can efficiently put the plate. So this is multifragmentary, but you can fix it efficiently if the cartilage is good. So this is how it was done. You can see the successive picture. Now the question comes, which way the rotation would be there. So this small flimsy loops of synovium tissue or the radial head periosteal tissue, this gives you a capability to judge how the rotation would be placed, because the whole fragments are displaced. So this is how it was done. And then you fix it with 2 screws, small screws, and then you can put your plate so that the radial head is. And slide the plate inside the muscle. The plate may not be very long. What you need is just 2 screws, because large amount of load is not there. So only this plate is usually good enough. So there are 2 types of plates. One is radial neck plate and another is radial head plate. Head plate comes up to this point. So this screw has to be buried in, and in the instrument set, there is a very small countersink available. That is very precise, so that the head screw is totally buried inside. So this screw is plate, small mini plate, and then the other safety guidelines are there, where to put plate and where not to plate. This is given very nicely in the text also. And this is how the radial neck plate is executed. You are putting interfragmentary screw from this zone to this zone. That is very imaginative when you are fixing multifragmentary fracture. So these were my small inputs. This also has been demonstrated to be done, that you can fix up the whole sector, fix from screw from this side to this side to this side, and then you can lock with a plate. This would only work as a spacer. But what I have seen in practice is this radial head also revascularizes very well. So occasionally, when you have initially completed good hands-on with multifragmentary, you can do this. So the screw length has to be very proper. Interfragmentary screw, this is the radial head plate. And then, so you can see 1 mm screw also holding very nicely there. A very, very small 1 mm screw for multi-fragmentary. And then you can execute it. There was one question from Rajendra Wankhede that everything appears to be hairware and soft tissues you are not able to recognize. But then if you are very careful, all the tissues have some attachment somewhere. And the wavy torn lateral collateral ligament also can be repaired very nicely. This is how it has to be repaired. This is a very typical stitch, the Krakow stitch, so that you get it back into position, drill out 2 bone holes, or put it through the suture anchor, and then you will be able to do it. This is the usual wound healing which happens, and then all this comminuted fracture radial head can be very efficiently managed. The interfragmentary screw remains the crux in multifragmentary fractures. That's all I wanted to present, sir. Thank you.
Excellent, Chandak Sirji. Excellent.
Sir, have you tried that tripod screw insertion?
I have tried. I will show a case also.
Okay, thank you, sir.
Today, otherwise
very,
next
very
time.
enlightening presentation, sir. Many fears have gone by now.
Thank you so much, Arjun.
Sanjay Desai, sir, I think.
Yes. Good evening, Desai, sir.
Good evening, Sanjay. Dr. Sanjay Desai, our today's guest, is here.
Yes, yes, sir. Yes,
sir. He is going to talk on a shoulder after Dr. Asim finishes his one case presentation. Asim, can you finish your presentation, please?
Yes, sir.
Sanjay, only one case presentation and you are on.
Whatever the high command says.
Thank you.
She is 52, practicing gynecologist, dominant hand.
You have to see completely. Just click on presentation.
Yeah.
We are seeing the icon of the presentation.
Can you see the slide now?
No, not yet. Not yet.
Not yet. New share. Now?
No, now we can see. Just make it full screen. Make it full.
Yeah, good. I made it full screen. She is 52.
Dr. Asim, you got disconnected?
Practicing gynecologist, dominant hand. Pardon?
Now we are able to listen to you. Yeah.
Yeah. So, this is her CT scan. The head radius, subchondral bone is very little on that side. There is some comminution of the neck and elbow is grossly unstable. So, classical incision, which Dr. Chandak was talking about, exposed in these injuries, most of the time, once you take the skin incision and go beneath the fascia, injury itself has done a lot of dissection there. So the plane is already created by the injury. This head radius at 55, we decided to excise rather than fix it. Once you keep the head radius on the table, there is enough room for you to see the coronoid tip and the capsular attachments around that tip. Fiber wire stitch around the coronoid. My suction tip here is showing the piece being reduced in its bed after we have taken this. So we did a sort of trial reduction, whether when we pull these sutures, it will fit into its bed or not, but precise reduction of that piece is not really important. It's the capsule which has been stitched over the coronoid base, which is important. The capsular attachment is important. But in this case, we could reduce that piece very well in its crater. Made tunnels in the previously I used to make 2 tunnels side by side. Now only 1 tunnel, and I tie these fiber wire sutures with over a endo button. And there is a very simple trick. I don't know whether it will come or not. Yeah. Radius neck had some comminution, so trimmed it 1 or 2 millimeters there till we had a stable base there and replaced the head radius. As I said that I asked for 3 or 4 companies, whatever is available, all the sizes and all the companies I keep, and whatever fits best, I use it. Here, this is a matrix head which gives options for the neck, but some other companies are also making good ones. The key to the sizing is that if you are in between sizes, you choose a slightly smaller size. Don't overstuff it. It will be painful and stiff. And if you go for very, very small size, unduly small size, then you may not be stable. This top has to match with this shadow in the ulna there. And on the lateral view, it has to be about a millimeter below the shadow of the coronoid here. And on the AP view, it should not be so proud that it is opening on this side, lateral side. This joint space has to be uniform. Reduce head radius, don't overstuff it. I brought out the fiber wires on the ulnar shin there, over an endo button, tied it, and we check the stability of the whole construct through the range of motion. Initially, it looked very, very stable. In all the motions there, collateral stability also was there. And all of a sudden, we realized that elbow has subluxed. So we explored the medial side. There were few small loose pieces on this side. When we went back to CT, we found that these pieces were stuck up there and we had not removed them. They were probably causing elbow to subluxate. Once we had opened it, then we repaired the medial collateral also and the flexor pronator mass which were detached. Joint became stable after removing these loose pieces, but as we were already there, so we repaired the MCL also, and this is after MCL and the flexor pronator mass has been stitched. Repaired with fiber wire, that's her X-ray, date and video. She was in a hinged brace in which she could do the exercises. This is the range on day 10. And around 5 weeks, she started operating, and 3 months post-op, and this is now almost 1 year. This is her function. Full range of motion, stable elbow, no pain, full pronosupination. Pretty heavy manual work.
Excellent, excellent, Asim. Any questions to Asim before we change over? Any questions to Asim?
Asim sir, Dr. Wankhede here.
Yes, sir.
When do you mobilize this patient post-operatively?
I showed you for day 3 or 4 in a hinged brace.
Okay.
And in a very dicey patient, patient is a gynecologist, so stakes were very high.
Right. Not for this patient only. When
all other patients. Today probably we will not get time, but next time I will show you tripod fixation also. I will show you a 75-year. So both the cases are nicely worked up and complete cases with follow-up. So
okay.
Yeah, I will show you next time. Yeah.
Okay, friends, I introduce you Dr. Sanjay Desai. You know, he is a shoulder surgeon and also the excellent arthroscopic surgeon of the knee. He is the one who operated upon Shah Rukh Khan and Sonia Gandhi, one of my very good friends. And here I hand you over to Sanjay Desai. I feel he is one of the rare situations where he is a wonderful teacher. And I'm sure you ask anything to him, he is going to answer. You may not be able to catch him if you want to really ask him afterwards, or even if you want to show a patient, it's damn difficult for him to really be available. Sanjay, all yours.
Thank you very much, sir. And special thanks to my guru, my mentor, my guide, my golf buddy, and whatnot. And I thank you all learned trauma surgeons. And I had to gather a lot of courage to speak on a trauma subject in front of you, big doyens in the field of trauma. But I sincerely hope, genuinely, that this talk makes you all very experienced trauma surgeons think differently and perhaps instigate you to innovate when it comes to fractures of the proximal humerus. So my first opening remark is I only do now in 2022 only 3 types of surgeries when I have to operate on fractures of the proximal humerus. Only 3. I repeat. Number 1, percutaneous wiring. Number 2, an intramedullary fixation device, which is an innovative device. Some of you might know, and I'll talk about it. And reverse shoulder replacement. I do not do, by and large, any other surgery except these 3. And in the next 15 to 20 minutes, I'm going to defend this slide. Now let's begin with a very simple relieving fact that 80% of the fractures of the proximal humerus are hardly displaced, and they do very well with conservative treatment, 80%. So please do not operate, no matter whether it is 4-part or 40-part. Do not operate if it is not much displaced. This is one of the classification which you trauma surgeons are very clever and you tend to use. Beyond me, mere bas ki baat nahi hai. I don't know how the hell you all remember this and apply it in your day-to-day practice. So I will rubbish it. And I will suggest to you my classification, very simple. Undisplaced and displaced, full stop. That's the end of my classification. If it is undisplaced, I don't care whether it is 4-part or 40-part. If it is displaced, then there are few special varieties that you must recognize. And they happen with remarkable consistency when you deal with fractures of the proximal humerus. One, a special mention is tuberosity avulsion, and I'll talk about it in a slide or 2. Number 2 is a 3-part valgus impacted fracture, where the patient falls on an outstretched hand, the head is kind of collapsing onto the shaft, and the tuberosity kind of enucleates out, and it's a 3-part valgus impacted fracture. You all must have treated many. Then, of course, the star fracture, the most controversial, the most difficult is the 4-part fracture and fracture dislocation. And that is going to be my thrust of my talk. Then you have occasional head split, surgical neck, and special situation. So now let's look at tuberosity fracture. I would recommend that when you deal with tuberosity fracture, be aggressive. This is what we used to do many, many years ago. And these days, it is pretty standard to do either an arthroscopic, or if the tuberosity piece is large, then a mini open, but using arthroscopy technique and anchors. Excellent result. Do not touch the tuberosity even if you had to open. Do not manhandle the tuberosity. Put an anchor on the medial side, pass it through the cuff, bring it over the tuberosity and bang it into the lateral anchor. That's the double row technique of rotator cuff repair. You may do it mini open, doesn't matter. But when it comes to tuberosity, even if it is displaced 5 millimeters or more, I would recommend reattaching it and fixing it with double row technique. No screws. Do not manhandle the tuberosity. Now, so 80% do well with conservative treatment, fractures of the proximal humerus. That means 20% are the therapeutic challenge. 2 or 3 part fractures, I do percutaneous wiring irrespective of the age. Some of you who deal with slightly younger patient with 2 and 3 part, you want to do a plating, you may do it in young patients. I have no argument. But I prefer percutaneous wiring, and I'll show you why in the next few slides. 4 part fractures is a real challenge. It's the subject of discussion. And I would welcome any number of questions once I finish saying what I have to say. So osteosynthesis for displaced 4 part proximal humerus fractures in young patients, I have no dispute. You have to preserve the head in young patients, whether it is a fracture, 4 part fracture, or whether it is a 4 part fracture dislocation. With the head lying in the axilla, still osteosynthesis is desirable. I have no arguments. I agree with you. The real question is when you have 4 part fracture or a fracture dislocation and the patient is above 50. And the fact is that majority of these 4 part fractures are in patients above 50. It's uncommon in 20s, 30s, and 40s, barring few high velocity road traffic accidents. And in this more than 50 age group, I have no hesitation in saying loud and clear that I've stopped using the plate, whether it is Philos plate, whether it is a gold plated plate or whatever plate, I've stopped it, and let me tell you why. These are some of the examples of failure. They have been done by experienced trauma surgeons all over the country. 1, 2, 3, 4, 5, 6. And if you cross your heart and ask yourself, how often have you come across these kind of failures when you deal with 4 part fractures, more than 50 age group? I can go on and on with all these failures, which are then referred to me. And then I have to do some form of arthroplasty or whatever. I'll tell you what I did in some of them. But the plating for 4 part fractures in patients above 50 is a challenge. Patient is young, below 50, yes, you will have a good result. But these fractures are not that common in young age group. Why this failure in 4 part fractures? Number one, the head is a thin shell, like a coconut shell. It's difficult to control the head. It's difficult to fix it. And equally difficult to fix and retain the tuberosities. And eventually, when you try to plate these difficult fractures, you end up with non-union, malunion, avascular necrosis, and a painful, stiff shoulder with poor shoulder function. That is not what is expected in 2022. Is it possible to give a better result? Let me try and convince you. First, you will have to agree, you must confess that there is a problem with plating osteosynthesis in more than 50. And the world seems to agree. So where has the world moved? If you have a 4 part fracture, which is displaced, needs surgery, you're above 70, there is a consensus, do a reverse shoulder replacement as a primary modality of treatment. There is no argument. Everybody agrees. The world agrees. That's what I do in my practice. But then what do you do if the patient is between 50 and 70? That's the question mark. Between 50 and 70. So let's just finish off above 70, reverse shoulder arthroplasty. It's getting more and more popular. A lot of you might know this is a typical case where I would do a primary reverse shoulder arthroplasty. This is a 4 part fracture. The head is completely avascular. Patient is 70. This patient wants an operation which is unlikely to need a second operation, and therefore a good reverse is the answer. Another example, 68, so almost 70, head split, comminuted, multiple pieces, reverse shoulder arthroplasty. In some situations, reverse might be the only option. Here is an example. One of Bollywood superstars' grandfather, 90 years of age, he came with this fracture. I said, let's conserve, he's 90. Within next few days, the family called up saying that he's in so much pain. Can you not do something? We are not very comfortable just leaving him in pain. And I followed all your lectures of trauma surgeons, and I did a nice, it's called a suture plate. It's like similar to the Philos plate with a very low profile. It's from Germany. And I think it's a good operation that I did. I hope you all agree. and I did some bone grafting as well. The patient comes back to me in another 3 to 4 weeks. They are not sure whether the old man had a fall or what, but this is what he comes with. In this situation, at 90, I don't think there's anything else one can do except a reverse shoulder arthroplasty. That is what I did. The patient lived for another 4 years after this with a reasonable shoulder function, and then he passed away after 4 years due to non-orthopedic reasons. So, should you do a hemi? The hemi results are unpredictable for 4-part fractures, and the world tends to think that the reverse shoulder arthroplasty results are more predictable. I will skip those slides. Now, let us look at some of you who will say that between 50 and 70, if I have a 4-part fracture, I will not do plating, but I will do a hemi arthroplasty. So let's do a hemi. So where is the current trend? What is the world feeling about this hemi arthroplasty in this age group for 4-part fractures? There's a problem. Example 1, the tuberosity is gone. Example 2, tuberosity gone. Example 3, tuberosity gone. Example 4, horribly done hemi. Day 1 failure. Example number 3 was done by me. It was a failed fixation. I did a hemi. Point is that to get a good result with a hemi in 4-part fracture in a predictable fashion consistently is extremely difficult. You will have these kind of failures in as high as 50%. This is in the hands of one of the gurus of shoulder surgery from France. He is perhaps the next man after Charles Neer in shoulder surgery. And even he feels that hemiarthroplasty for 4-part fractures, the failure rate, the unpredictable behavior is so high that it is not acceptable, 50%. You may have one case like I'm going to show you with a successful result. Tanna sir might show me a good hemi result, and I will also show you. But it doesn't happen with consistency in a predictable fashion. Here is a 56-year-old man, 4-part fracture, comminuted. I had done, I think, 15, 18 years ago, and see the result of hemiarthroplasty. Almost full function, external rotation, forward elevation, and internal rotation. So excellent function with a hemi. But this result is only because if you look at the X-ray, the axillary view on the right, see how beautifully the lesser and the greater tuberosity have healed. Now the problem with hemi is you cannot get this beautiful healing of the tuberosity with consistency. I'll tell you some secrets, which if you wish, you may try. Treat hemiarthroplasty and reattachment of the tuberosity as augmented osteosynthesis, not as a arthroplasty. You must get union. And to achieve it with consistency, you will have to be absolutely perfect at reconstituting the anatomy. The prosthesis height, if you make an error more than 14 millimeters, this is the Lakshman Rekha, you will have a failure of tuberosity. If you make a mistake in the version of the prosthesis by more than 10 degrees, you will have a failure. And therefore, do not underestimate hemiarthroplasty for fractures of the proximal humerus. It's not so simple. Canal khola, cement dal diya, or prosthesis ghusa diya andar. It doesn't work. You will have a failure on your hand. And a cuff deficient hemi is worse than conservative treatment. So now, between the age of 50 and 70, if I prefer not to do plating for 4-part fractures, if I'm against hemi, then what do? This is what I do. This is one of the implants, which is from France. I've published in an international journal, which is one of the leading journals, Journal of Shoulder and Elbow Surgery, the results. And I'll give you the reference, whoever wants it. I'm in the process of designing, improvising this implant and designing a new one. It's in the pipeline. Let me give you an example of how to use this implant. Here is a 48-year-old male. He had a comminuted 4-part fracture, as bad as it gets. This gentleman also had a vascular injury. So fortunately, we picked it up, got the vascular surgeon. He put a graft there. And this is the implant. And look at the result. "12 months post-op. There you are. Example number 2, 68-year-old right-handed male. badly displaced, intramedullary device, 8 months post-op, all healed nicely, good function. Example number 3, 52-year-old female, 3-part, again did an intramedullary device, healed, beautiful, constant score is 96. Example number 4, almost a head split fracture. If you can see the plain X-ray and the CT, I started getting bolder once I got familiar with the implant. 52-year-old male, no way that I'm going to do a hemi. Fixation is going to be a nightmare as well. So I did an intramedullary device. Even the head split has healed beautifully. If you see the 10-month post-op X-ray, this patient has a constant score of 90. Somebody did a exotic rush nail with tension band, and then patient came to me soon after the surgery. He realized it's not going to work. I removed those rush nails and did a just unique, healed beautifully. This is post-op. One more example, 64-year-old male. I did a intramedullary device. Usually I do through the McKenzie superior approach, but I want to show this case and warn you that if there is a butterfly fragment somewhere in the shaft area, which is likely to make the stem unstable, please do it through deltopectoral approach, because I had committed to the superior approach and I did not bother to fix that butterfly fragment. So I had a failure of this implant. I revised it to reverse a few months later. So if you have a fracture which is extending down to the shaft, and you may need to either do a cerclage or whatever form of fixation to stabilize that piece, please do a deltopectoral approach for this implant, though it is described for superior approach. Here is the link, the Journal of Shoulder and Elbow Surgery, 30 cases, constant score is about 74, union in 93.3%. This is more than 2-year follow-up. I had in complications, 2 cases of AVN, only one was symptomatic enough. I could do a hemiarthroplasty only because though the head was avascular, the tuberosities had united beautifully with this implant. Now I'll show you another extension of this implant. This patient had a very badly comminuted head split proximal humerus fracture. Patient is only 58. Once the patient is 58, I will not want to do a reverse. So this is known as just hemi. So what I did is I extracted the head. You can see that it's a head split. I made a hole in that patient's humeral head, put a cup through that hole, and this head is lying inside the cup. And now you do just like a just unique. What happens is you have a nice autogenous bone under the cap, which enhances the possibility of the tuberosities to unite. The key in proximal humerus fractures is to get the tuberosities to unite. So this is what I did. I did a just hemi. This is not just unique, just hemi, where the head is inside that cup. And if you can see here, the tuberosities has united. This patient has a constant score in 80, 6 months post-op. So for 50 to 70 age group, I would do a just unique. And if it's a head split, I would do a just hemi, where the vascularity is suspect. The take-home message to all my learned colleagues, if a patient is less than 50, a 4-part fracture, you do osteosynthesis, whichever method you like. If you like plating, you are expert at plating. In young patients, go ahead. Though I may not do plating. But if the patient is above 70 and you have a 4-part fracture, reverse shoulder arthroplasty. And the real challenge is if the patient is in between 50 and 70, then this is what I would do. Just unique or just hemi when the vascularity is suspect. So here is a summary or a take-home message. 2 or 3-part, irrespective of age, I do percutaneous wiring. Excellent results. I take 30 minutes to do it. It's under block and sedation. No GA, patient goes home the next day. Excellent results. 4-part fracture, more than 70, no dispute, reverse. Between 50 and 70, I would do a just unique or a just hemi. Please don't take proximal humerus fractures casually. It is very, very difficult to get a good result. This is a 70-year-old male. Somebody did a fixation for proximal humerus fracture. Then the patient went to someone and got a hemi done. Hemi failed, was changed to reverse. the reverse is unstable. And then I had to do the surgery for the 4th time to revise this reverse to a reverse again. So do not underestimate reverse shoulder arthroplasty as well. Here are some of nightmarish situations. Another reverse shoulder arthroplasty done for fracture, and there is a disassociation of the assembly. Displaced 4-part fracture, particularly under 70. We all need to think a little different. Think different, understand the biomechanics, and you may want to innovate. Just Unique is just an example. It's not the end point of this innovation. I end my talk with one of my favorite one-liners. A lot of people used to think I'm an arthroscopist, but I'm not an arthroscopist. They all know now, I think. Because I cannot see pain through the arthroscope. Thank you once again.
Dr. Sanjay.
Yes, sir.
Can you explain about the unique? Because I think majority of the people are not aware of the unique implant.
Okay.
So I think some of us who are in Bombay and who are in the metros are using it, but it is otherwise not very easily available. And not many people are doing the ortho is just unique. So I think if you can talk about a little in a deeper version of a just unique.
Yes, sir.
Sanjay, last time you showed percutaneous K-wiring also. So how you do it? Just few slides.
Okay. Can I first deal with sir's request?
Yeah.
So now, I think the basic problem in plating is plating has ignored completely the biomechanics and the forces that are being transmitted through the proximal humerus, particularly the cuff attachment and the tuberosities. And therefore, I think we must innovate. I'm not saying this implant is the final stop. I am in the process of making a new one myself. As I said earlier, I'm in collaboration with IIT Mumbai, and in the process, you will have it perhaps in a year's time. But now this implant, what you do is, it has 2 components. It has a staple, which you see in the head. The staple has a central, like a peg, it's hollow. Now you insert the whole operation is done under fluoro. I keep the fluoro all the time, not bring in and out. It's there around the axilla of the patient. I do a superior approach, but like I said, you may do the deltopectoral. I like to do the superior. I do all my primary reverse with superior approach. First, I identify the 2 tuberosities and secure them with ethibond, passing through the tendon. Do not hold the tuberosity with towel clips and cockers, artery forceps. Think of tuberosity as a nice, lovely woman. Do not manhandle. Do not touch it. Because tuberosities are feminine. They are very sensitive. I'm telling you this after 30 years of shoulder surgery. They will disappear. They will go into, they will dissolve. They'll go into non-union. So secure the tuberosities by passing ethibond into the tendon bone junction. Don't touch the bone. Now, once you lift the tuberosities, do a biceps tenodesis or a tenotomy at least. And then you will see the head, the fractured surface of the head. Under fluoro, you pass the staple. Staple has a central peg which is hollow, and it's got a handle to hold it. You pass the staple in the center of the head. The cut surface of the head is sitting right in front of you. It's facing you. You pass this staple, check on Siam that it's parallel. It's in the center, parallel to the fracture line, as you can see here. Then leave it there. It's impacted into the head because it's got those broad staple-like projections, 5 or 6 of them. Now leave it there. Then turn your attention to the shaft. Prepare the shaft. Pass this stem. The stem has a telescoping sheath around it. If you see here, the big triangular thing is a sheath with which you can increase the height, because every tuberosity fractures at different level. They are never the same. So once you pass the stem, you engage the stem into that hollow of the staple by a Morse taper. So far it is clear there is a Morse taper on the stem. that Morse taper engages into the staple. And once you engaged it, it just falls in place. It reduces beautifully. Now, all you need to do is increase the height depending on the length of the tuberosity, because you want the tuberosity neither under tensioned nor over tension. Otherwise, you will have a problem. And once you adjust the height, you can have 1, 2, 3 different distractions of around 4 millimeters each, up to 12 millimeters, so that the tuberosity falls in place in a perfect position. You re-achieve the height of the proximal humerus, the Gothic arch, and then you tie the tuberosities into the shaft. It's as simple as that. Because before passing the stem, I've made holes into the shaft, kept the ethibond there. The ethibond and the tendon are already there, and I tie the two together, and it heals beautifully. I hope that helps you, but you're welcome whenever you want to come and watch. Only thing is, you'll have to bring 2 cases for me to do at my charges.
And his charges are far too different.
I was just tickling, sir. I knew it. So anyway, you're most welcome whenever you want to watch it. But it's worked beautifully. This paper is published in Journal of Shoulder and Elbow. Those who are not familiar, because you are a general orthopedic surgeons, I do appreciate that. JSAS is the #1 shoulder journal in the world today. Now, the second question was about the... Any question? Any question? Yeah.
K-wires, how you do it, you say?
Yeah. Now, I don't have, but I can show you. Yeah, last time. Just give me a second. Okay, now let me show you slightly more. This patient is 42. So you have 2 options. It's a 3-part fracture.
Now you're not sharing the screen, Sanjay.
Oh yeah, okay, hang on.
Yeah.
So this is now, let me...
No, it had come just now.
Yeah, no, I only took it off. I want to show you. Yeah, now if you see this.
No, again, it's not there.
Okay. Can you see now?
Yeah.
Yeah. Now what I do is, first of all, I would do this in 2-part, 3-part fractures, irrespective of the age. I repeat, if the patient is young and you guys, trauma surgeons in young patients, want to do a plating, go ahead. But I would do a percutaneous wiring. Once I reduce the fracture under fluoro control, I will pass 2 K-wires first from the shaft into the head and try and be in the inferior quadrant. Remember that there is a tendency for the head to go into varus. That's how the forces work. And these are threaded tip wires. Once I pass those 2 wires in 2 different quadrants, anterior and posterior, but in the inferior part, then I will pass a wire from the edge of the acromion through the bare area of the humerus into the canal. And the fourth wire will go through the tuberosity engaging into the head if the tuberosity is fractured and unstable. So let me try and show you one more. Okay, I'm going to show you one more now. A valgus impacted fracture. This lady is in 60s.
The slides are not shared.
No, I'm sharing them because I had not prepared this. So I'm showing one at a time. You'll have to bear with me. I hope time is not a constraint.
Yeah.
Can you see this fracture?
Yes, sir.
So this is a very typical valgus impacted fracture. How does this happen? When a patient falls with the arm outstretched and the head is axially loaded with tremendous force, if the patient is overweight or if the fall is such, then the head will kind of crush onto the shaft and the tuberosity kind of enucleates. I hope you understand what I'm saying. Now, you need to reduce this, and I'm going to show you. And here I'm going to show you now can you see it?
Yes.
So again, the same principle. I will reduce the fracture, pass 2K wires first from shaft, from distal to proximal, engaging the inferior quadrant of the head. And then I will pass, if the GT is displaced, I will pass a 2mm K wire from GT into the head again. The inferior K wires from going from the shaft to the head, I always use 2.5. The one going through the GT is 2 mm. And if I have to pass one from the bare area of the head into the canal, it will be 3 millimeters.
Excuse me, sir. All wires are threaded wires?
Threaded tip. Not fully threaded, threaded tip. And please remove them in 3 weeks' time. You don't need it longer than that.
And the GT wires don't have to engage the shaft.
The GT wires go into the head. Okay, I'm going to show you one more.
Sanjay, here at times when I'm putting the wires, if the GT is displayed, I do the small deltoid split approach, reduce the GT and do a small tension band to the GT and carry on with the wire, because the GT always doesn't come by close manipulation so perfectly.
Yes, sir, you can do that. But to be very honest with you, sir, I have never had the need to do that.
Mm-hmm.
And I have a fairly large series. Is this X-ray visible?
Yes.
Okay. You can see this is a badly displaced, and see this. Now, in this case, the tuberosity was not fractured and displaced. So I didn't have to pass the tuberosity 2 mm wire. I passed 2 or 3 in this case, distal to proximal, and one from the GT bare area of the head into the canal. Is it visible?
Yes, sir.
Yeah.
Yes, sir.
So the wire in the shaft won't toggle?
No, why would it toggle? Patient is in an arm pouch for 3 weeks, allowed elbow extension and hand movements.
When you keep the limb abducted in abduction or?
Never. In a simple sling, arm pouch.
And I presume the way the wire are, you are keeping them outside the skin.
Yes, yes. But not to keep them too long.
Yeah, yeah.
So by threaded tip, you mean the normal that we get in conference, they have around 1 centimeter area, they have thread in the tip. That only or something different?
No, no, that only. That
and
only.
For isolated GT fracture, how do you manage them?
Were you there in the first part of my talk? The opening was, number one, be aggressive with tuberosity fracture. Don't be conservative. Even little displaced, fix it. Number two, never use any metal. Number three, do not manhandle the tuberosity. If you want to do, you're not familiar with arthroscopy, doesn't matter. The result is same. Do a mini open, do a double row technique. You'll have to learn the double row. Does that answer your question, my friend?
Yes, sir.
Yeah. Now,
so if you have its cases or video that can all, if you can show them.
Cases or video.
Excuse me, sir. Good evening, sir.
Yeah, go ahead.
Should we remove the K wires irrespective of age in 3 weeks, sir? Or should we wait for more?
Yes, remove them.
All right. Thank you, sir.
Okay, now I want to show one more case. She is 37 years old. Are you able to see this slide, or is it too small a picture?
A bit smaller, sir.
But we are able to catch up the things, no problem.
Yes.
So I will open it in stepwise. Okay, so can you see that now?
Yeah, better.
So it is an unstable fracture. I will show you the CT scan. Look at this. Sorry, I should have covered the name, but anyway, she's 37 years old. And watch this. Can you see this now?
Yes, we can see.
This girl had 100% constant score. You'll have to trust me. I have a video of her shoulder function, but it will take time to fish it out. But this girl, 37 years old. Now, I know at 37, the bones are good. A lot of you people would have done a plating for this patient. But believe me, the patient loves it. She's so happy that I didn't give her any scar. I took 30 minutes under local, under block, no GA, and the patient goes home same evening or next morning. And like I said earlier, I will pass 2 wires from distal to proximal, again the same in the inferior quadrant, one engaging the anterior part of the head, one engaging the posterior part of the head. Then I will pass the GT wire, and then I will stabilize the whole construct with a 3 millimeter, which is a rather thick wire going from the bare area. Where is the bare area? Where the articular cartilage ends. There's a bare area. That's the entry point, just anterolateral corner of the acromion. But I must confess that you have to be very familiar with the shoulder joint and the internal milieu to do it effortlessly. I do have a little advantage of going in and out of shoulders every day. So it's very easy for me to do that. But you guys being good trauma surgeons also will be able to do it quite easily because you're used to handling K-wires and all that. So I think you should pick up this K-wire technique. No doubt about it. Let me show you some more case. I have many to show you. I want to show you a nasty one. Yeah, I found one. This patient is 83 years old. Okay, I found. Okay, you can see that?
Yes, sir.
Okay, now it's a display. See, the head is completely off the shaft. Can you see that?
Yes, sir.
So naturally, any one of you would have conserved it, saying that 83. Please, somebody speak up if you think you could have conserved it.
Yes.
You would have conserved it?
Yeah.
Yes, sir. Conserve it.
Even if the head is completely off the shaft?
Yes, sir.
Okay. So this is what it was. The head is completely off the shaft. The shaft is lying posteriorly. So this is just one step more than conservative treatment. This is the axial cut. And this is what I did. No cut, no GA, underblock, local anesthesia, K-wiring, and this patient did extremely well again. Extremely well. So, yes, if you had to open and put a plate, it would be a disaster in this case. And therefore, those who are not...
Can you give any tips about reduction techniques?
I think, तो आप लोग मेरे को सिखाना चाहिए.
It is very difficult if we do close, sir. Open, we can do anything.
Closed. अभी आपको और एक तो दिखाता हूँ. So next time आप आर्थ्रोस्कोपिस्ट को थोड़े सम्मान से देखोगे. Let me show you a terrible one. I'm trying to find. Yeah, I found it. I found it. Yeah. Okay. Sorry, I didn't prepare myself for percutaneous. But it's okay. It's fun seeing it like this also. So here is this patient is 78. You can see this. I think it's a 3-part fracture, quite like a valgus impacted fracture. Would you guys have conserved this?
Yes.
Conserved it. You see the greater tuberosity?
This cannot be conserved.
So that's why all proximal humerus fractures should go to a shoulder surgeon and not a trauma surgeon. because being a trauma surgeon, you look after such complex trauma that you ignore the shoulder function. अरे इसमें क्या है, थोड़ा हाथ ऊपर नीचे नहीं होगा, चलेगा. That is not what a patient wants. Look at this. I don't think, look at this. Look at the GT. How do you expect the gentleman who wants to conserve this, how do you expect this shoulder to function well? If you see Dr. Tanna play golf at 84, you'll be amazed. You'll be amazed. He beats us. So you expect this 78-year-old ka chalega? Shoulder function kaisa bhi. Why?
So with Philos, it would give worse results.
Yes, exactly. Because Philos is a bad invention. It should be banned. And look what I did. Here is the age, 78 years old. This is what I did. Again, she did very well. Extremely good result. If you are still not convinced, I can show you.
Open the GT also or only wire for GT?
I have never had to open. Kabhi nahi khola hai maine. So let me show you another deadly one.
Sir, what is the distance of the lateral K wires from the acromion? Is it? I presume it is less than 5 centimeters.
Lateral K wire from
the 2 wires which are going from the shaft into the head of the humerus.
Oh, they are worried to injure the axillary now.
They are far away. So
yeah,
yeah, they are far away. See, I always start my operation in a beach chair. I do my drawing, the marking on the skin, every case. Just as I do in my arthroscopy cases, even after 30 years, I will do the marking. I know exactly where the axillary nerve is, and I am several centimeters distal to it. So acromion se to bahut dur hai beta.
Okay.
So this patient is 75. Again, head is completely off. इसमें क्या plate डालोगे? But you can ask me, you can argue with me why I don't do a reverse. I said I will not do a reverse unless it's a 4-part. This is a 2-part fracture or 3-part. It's not a 4-part fracture. See this? Here it is. The GT is part of the head. The GT is part of the head. Here. So a simple operation like this, which I will show you here. Again, excellent result, did very well. If you want to see the axillary view, the 2 K wires from the shaft are engaging the anterior and the posterior quadrant of the head. I go back here, these two distal to proximal. And the tuberosity wire can go horizontally into the head or can go obliquely, doesn't matter as long as you retain the tuberosity. And just from the anterior edge of the acromion, this 3 mm wire will go into the canal.
Why do you use that 3 mm and other ones are 2.5 and 2? Any reason for that thick wire?
Yes, sir, because in all these cases, the bare area of the humeral head is very strong bone. So it's almost working like a nail, sir, intramedullary nail.
Okay.
So it's a very solid way of retaining the head and allowing it, not allowing it to slip in varus. If you want to see,
you go on with touching the acromion medially from posterior to anterior. That wire?
It is coming from the top. You see the anterior angle of acromion?
Yes.
The anterior angle of acromion is just going to be, remember, a large part of the head is anterior to the acromion. So if you select the anterior corner of the acromion, it is easier to hit the canal.
Thank you.
You got it?
Yes, sir.
Yeah. Now I can show you some more if you are still keen. This looks like a simple one. Yeah. It's a relatively easy one, but still you can see it. Easy one to do.
The majority of this can be reduced on traction, and then whatever the small angulation with the joystick, you will be able to put them back into the position.
Correct, sir. And even the joystick, I don't need much. So here is another example. This patient is, I don't have the age, but it's off the shaft. It's a 2-part fracture. Now, irrespective of age, I mentioned in my talk, 2-3-part, irrespective of age, I will do percutaneous wiring. So therefore, no reverse, whether the patient is 70 or 80. This is what the pre-op is. And this is the, once again, same thing, same concept. First 2 wires distal to proximal, then fix the GT, and then the intramedullary wire.
So if in the similar case, the fracture is little down, say surgical neck level, then what do you do?
Now, surgical neck, can you tell me the age of the patient?
45 to 50.
Oh, that's pretty young. So surgical neck is a different baby altogether. I would, to help you understand, I will compare it to your subtroch of the femur. So one is, if the fracture is stable, then try not to do percutaneous wiring in a similar way. But if it is unstable, then I would plate that with bone grafting.
Thank you.
Nowadays, that sort of a fracture is also treated with the nails which are available.
Yes, sir. And there are nice nails available.
Nice nails are available.
Multi-long.
Yeah, multi-long.
Dr. Desai, when you remove these wires at 3 weeks, are there no secondary subsidence or varus valgus displacements?
Yes, there can be a mild alteration in the reduction, but nothing to compromise the result.
Okay.
So is there any role or any advantage of using fixator pins or clamps outside to attach the wires?
Not required. Makes no difference. I know the BB Joshi gang work, but it's not required.
The results have been very peculiar. With the Philos, the range of movement which you get is almost never 100%, or it is never even 80%. While with these K-wires, even though you feel that K-wires are removed there, they are immobilized, they are not fully mobilized for so many days. But the end result, the range of movement is very, very good, about 90 plus.
Absolutely, sir. You said it. I completely agree with you. So now if I summarize my thinking, 2 and 3 part, any age, I will do percutaneous wiring. 4 part, above 70, I'm going to do reverse. So bacha kya between 50 and 70, that's the only catch. Between 50 and 70, you guys will have to innovate and think of something different. Or wait for my design in a year's time.
Why, you are not that happy with this unit?
No, I think there is potential for further making it even better. I'm happy, but I know I can make it better.
So even if the median...
So here is another one. I'm trying to check the age of this patient, but to give you an idea, but we'll find it somewhere. So again, displaced. It's not 4 part. It's perhaps 2 part.
And I presume you get a CT done in all cases.
In all cases, yes, sir. Always. So here is the... And this is the... Any questions? I hope I have shown enough to convince you that...
Absolutely.
And sir, as leading trauma surgeons, you all are aware and you agree that the world is doing reverse as primary if you are 70 and above, 4 part fracture.
That's what we have learned from you.
Yeah, 70 and above. Sir, the reason is very simple. At 70, if I have a fracture which needs intervention, say 4 part displaced fracture, I want an operation which will not require a second operation.
Yes.
As simple as that. But reverse is not so easy. If you do a bad reverse, you will end up with a disaster. So always call me.
So you know the meaning of this sentence. So don't
Always
try
call
reverse.
me.
Send it to Sanjay.
So this is the post union. This patient.
Yeah.
Sir, in a young patient, even if the medial calcar, the calcar length is less than, suppose, 8 millimeters, or if the medial hinge is disrupted, you still go for a percutaneous K-bar fixation? I mean, can we go for it?
If the medial hinge is disrupted, you are worried about the vascularity, correct?
Yes, sir.
How will the vascularity problem be reduced or increased by doing a plating?
No, because I suppose when we basically pass a calcar screw, we are trying to, maintain that.
main hinge गया medially तो vascularity तो जो होना है होने वाला है वो.
Okay.
He's talking about the stability part.
Yeah. Basically, both the things, sir. Stability as well.
He is so much enamored by the strut screw.
Yeah. No, वो सब strut screw, front screw कुछ काम नहीं करता है proximal humerus fracture में. Even if I understand what you're saying, if there is a medial fragment and if it's unstable, still it seems that meaning minimally invasive, not opening and further compromising the vascularity seems to work very well. Very well.
Please also see, he's talking about 2-part and 3-part. He's not talking about the 4-part.
Yes. Now 4-part. I will again summarize 4-part. 4-part above 70 reverse, no dispute. Below 50, आपको जो टेक्निक पसंद है आप करो, रिजल्ट अच्छा आ सकता है. प्लेटिंग भी करो. Below 50.
But below 50, you do only the wiring. Am I right?
In a 4-part, sir, I'm talking about 4-part now.
Yeah, 4-part.
So let me repeat. 4-part, I don't do wiring.
What do you do then?
So
in a 4-part young patient.
So let me again summarize. 2 and 3-part, irrespective of age, if it needs intervention, percutaneous wiring. Let's keep that aside now.
Yes.
Now 4-part. 4-part above 70 reverse. Below 70, between 50 and 70, I will do just unique. Below 50, I will do just unique, but you may do plating. No problem. I have no objection. Am I clear, sir?
Yes, you are.
But I will not do plating. I will do just unique below 50 as well. Like I showed that guy with vascular injury. I can go to just unique folder if it is.
Sanjay.
Yeah.
You manage to avoid varus when you are hammering that stapler. How do you prevent it going in the wrong place and having a varus reduction?
That's the beauty of the whole construct. Your stem is intramedullary.
Yes.
The hat has to sit. The hat means the head. The hat has to sit on the shaft. The construct automatically makes that happen. The staple is engaging into the head, and the staple is sitting on the stem by more stapler, so it doesn't fall into varus.
I think those of you have not done just unique. It's a very, very special implant, which is once you've done it, you are so much satisfied with the whole result that it is not replacement, it is a repair. It is you have done only the repair of the fracture, and almost I entirely agree with Sanjay. Though I have done very, very few, but it is a very good implant. But I had not taken it the way you are mentioning, that anything like this between 50 and 65, you are doing only just unique.
Now, I want to show you something even special. This was an interesting case. Let me show you this. Yeah, this is a nice case. I don't mind taking the name also. Sir might know this મલકાન નો ભાઈ છે સર.
ઓકે ઓકે.
આપણે
ભાઈ મલકાન નો દીકરો. અમિત મલકાન, yeah.
So he is 61 and this is the fracture he had, sir. Now if I show you the CT here, this gentleman is 62. So I don't want to do a reverse. He's 60 years old, 60. Here it is written male 60.
Yeah.
Now, let me ask, you all are very senior, experienced trauma surgeons. Take out just unique from the scenario. What will you do? क्या करोगे इसमें? नेगी साहब, आप क्या करोगे?
Refer to Sanjay.
I love you.
So some of the basic problem here is the head part, the articular portion of the head is sinking in.
Yes, quite right.
So once you elevate it, maintain it in that position by any means, this should give you a good result because the tuberosity envelope is in position.
Okay, so now that is the catch. Hold it in a corrected position by any means. I am reiterating what you said. वही तो लफड़ा है, तुम्हारा प्लेट नहीं पकड़ सकता उसको जगह में.
Yes.
That part of the head has very little bone there.
Correct. Yes. It's like a coconut shell.
Yes.
So the problem with your implant is on table शायद थोड़ा अच्छा भी लगे, but it's an eyewash. In trying to fool others, you are fooling yourself. It doesn't hold. ये देखो, ये CT scan देखो. Now, somebody mentioned about the medial cortex and unstable fracture. Now, I will show you what I did. This is as bad as it gets. Yeah, boys?
Yes.
Now, here is my
boy.
And I have a video which let me see if I can. He is now 1 year post-op. And that video is not loaded here. But sir, give me a second. You'll be amazed.
Would like to see that.
Yes, I'm trying to find the video. Abhi follow-up में अभी आया था around few weeks back. So I know I had taken a video because I know you trauma surgeons will not leave me alone. क्या साला झूठ बोलता है, उल्लू बनाता है.
No.
Let me. So
every word you have spoken, every sentence, you are taking it as you have spoken.
मैं तो मजाक करता हूँ.
So these are lifetime experiences we are getting. So
yes.
So
let me. I don't know how to.
The only thing from all the majority surgeons, if I speak, the plate may have a subset of patients who have bad result, but not all.
Sorry, the plate may
have a subset of patients where the plate has done badly, but not all the plates would do badly.
No. I'm not. Nobody is saying that.
Yeah.
But the failure percentage is unacceptably high. That's the point.
Yeah, that is what is acceptable. Fine.
So वो आज 2022 में वो नहीं चलेगा.
Understand?
Yes.
Pandey from UK was there, like Sanjay.
Yeah.
He does those screws. Instead of wire, he was using screws. But we are over-utilizing the philos, though it's not giving great results.
Yeah.
These people, they use either wires or percutaneous screws and reduction techniques and all those. They don't open the envelope and don't hesitate to keep patient sleep for 4 weeks, 3 weeks.
I think philosophy, I would not take it as a plate. It's a concept of repairing 3-4 part fracture with tuberosity coaptation, with void filling, with correct application of plate would give you good results.
We are overutilizing it.
Possibly, yeah.
Even before the philos came,
J wires, they will work wonderful.
Before the philos came, we were all using K wires and maximum is the tension band for the GT.
Yes.
This was the treatment.
Yes.
Chandak sir?
Yeah.
The case that Sanjay sir showed.
So, last one.
Yeah, last one, yes.
Yeah.
In that case, if you want to do philos and you put a fibula strut graft to keep the head fragment in position, do you think that will work?
See, we have to realize that what has happened there, the articular central fragment of articular shell of the humeral head is intact, but it is sunken in, and in periphery there are 4 fragments which are all adjoining the fragment, and they have risen above the shell.
Yes, sir. Yes, sir.
Right. So now what is required is the shell was brought to its position by just tuning. All other things went back into position. Possibly either they are held by sutures or they are just adopting by soft tissue tension, and the stem raises the head. That is what is done. You do this by any methodology, that would work.
Got a video? You got a video?
Yes, sir. I got the video. I just need another 10 seconds.
Yes, sir.
Yeah, carry on.
But I'm going to comment on that. Somebody made a remark about fibula intramedullary.
Yeah.
Superb results. I would recommend that. Suppose you don't have familiarity with this implant, then in such cases, intramedullary fibula is a published fact that they do very well. You can do that with the plate.
So
thank you very much, sir.
So cheerful and happy to know that.
Yeah.
Yes, sir. Yes.
Right.
Something which has been endorsed by Sanjay.
Yes.
What we do.
We are on the home territory.
Sir, a minute. I am almost there. Yes, I got it. Yeah. Okay. Now. अरे उसका वीडियो नहीं आया.
वीडियो इधर है ना? नहीं, ये तो खाली अच्छा फाइल है खाली.
हाँ. This fellow's head was almost on the table when I was operating. It was totally denuded. But let me see if I can.
So even in a completely denuded head, just tunic would hold it into position and
yes,
sort of revascularize.
Yes, in this patient here is the AP. It's all healed. He's got superb function. I'm just trying to. I didn't manage to get.
I think you will have to show us the video because that is what is
the key.
Yeah.
The convincing thing.
Yeah.
No, but we believe that he must be having a good function this is very nicely. This is very nicely
healed anatomically.
Yeah, this is healed.
Superb healing.
Yeah.
No, you should not believe. Give me a second. You should not believe. Let me show. Here, I got it.
Yes. Malkan Bhai is seeing there. So he seems to be a very prominent VIP person.
He is one of the GP's brother.
Okay.
We all know the GP. And your Malkan one didn't come here on the desktop.
Yeah, I don't know where it went.
It may be on the desktop somewhere you can see around.
Yeah.
Sir, it is in the second folder. That MP4 file is there. Yeah, this one. MP4 file is there.
There you got it. You got it. MP4.
Kidhar hai?
Just in.
Just below the first highlighted JPG.
Yes.
Down below
Six.
that.
Below that.
That
Yeah,
down
just
below
below
that.
that.
Between the two blue.
6 from the top it was.
In the same folder,
thing
sir.
open. There
Yeah,
it is.
6.
There it is.
Yeah,
Yes,
yeah,
sir.
yeah.
Yeah.
Lovely.
Hats off to you, Sanjay. Thank you very, very much.
Thank you, sir. Thank you.
Lovely.
Beautiful.
Lovely.
Lovely. Absolutely beautiful.
Sanjay,
Yeah.
still quite a lot of you is remaining.
Thank you, sir.
Can we meet next Thursday?
Next Thursday is what, sir?
Next Thursday should be fifth time. Fifth.
5th for
6th. It is 6th October.
For the same thing.
Yeah. नहीं अभी तारो reverse ने બધું બાકી છે ને?
I think more or less it's covered.
The exact execution of a reverse.
Acha, execution.
Yes.
6.
No, you have to show us the reverse. And even a good hemi.
And
About
GT
hemming.
fracture also.
So, but only thing is 6th October, sir, I may not be available. So I will be happy to speak on.
6th October, Thursday. Yeah.
I am likely to be out for dinner.
Okay. So wait.
But the topic I can suggest is shoulder arthroplasty.
Yeah.
And I will cover the whole range where we are heading in the world of shoulder arthroplasty.
Okay.
Perfect.
And where does India stand?
Right.
Or where does you stand? Is it in India?
अभी आप वो जो आप समझो sir.
Okay. Thank you, Sanjay.
Thank you very much.
So hopefully on 12th or 13th.
Let me know, say a few days in advance, so I'll just...
No, 6th if you confirm whether you are busy or not.
6th, I am busy, sir. I know there is a dinner that I have to go to in the evening.
Okay, then I think on 13th.
Yeah.
So will you please lock 13th?
13th, sir. Shoulder arthroplasty.
Okay. Thank you.
Thank you, sir. Thank you.
Thank you, friends, everybody. It is already now time.
Thank you, sir.
Thank you. Thank you all. Thank you for having me. I enjoyed it.
Sanjay, it was superb.
Thank you, sir.
I heard you enough times, but still I think every time I hear it is enjoyable.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you.
Thank you
very much, sir.
Okay, friends. Bye.
Bye.
Bye-bye.
Thank you.
Bye.
Good night.